Okay, thank you very much. So I'm really looking forward to this next talk. There are so many areas that we as a society discuss constantly, and none as controversial perhaps as the use of alcohol, drugs, and tobacco. So then one might ask, why don't we discuss it? Why don't we hear more about it in the institutional setting? Are the issues the same in the general society as they are in institutional settings? Are they exacerbated? Are they fewer? I look forward to exploring this issue, and we have our panel here, and we'll start with Ellie. Thank you, Ellie.
So hi, I'm Ellie Weston. I'm with Vancouver Coastal Health. I'm with the Tobacco Control Program. Okay. I'm Ellie Weston. I'm with Vancouver Coastal Health Tobacco Control Program. And so I'm going to talk a little bit about tobacco in institutional settings. I need to disclose that I have nothing to disclose. And I want to talk a little bit before I get started about Vancouver Coastal Health Tobacco Program. So the tobacco in Vancouver Coastal Health, we have a comprehensive tobacco strategy. It is based on sort of that four-pillar approach. So there is a protection component, which is the stuff that you see around municipal bylaws in Vancouver and throughout Coast Garibaldi, or through Vancouver Coastal Health. There is a prevention piece, which is preventing exposure and some of the work that gets done in schools around preventing the uptake of tobacco. There's an enforcement component, so within the Tobacco Control Act there is legislation around sales to minors, and then there is a treatment or tobacco cessation branch. I sit in the tobacco cessation branch in the clinical smoking cessation program. So what I thought I'd do today is, I don't know what the understanding in the room is, so I thought I would go over sort of what tobacco is and sort of the physiology around that, talk about why in residential care it might be important to address, talk about approaches and resources. So, okay. Oh, I went too far. I'm sorry. So what's the big deal about tobacco? Well, tobacco is the only legal product that we have in society that kills 1 out of every 2 users when used as intended. Tobacco causes 35% of all lung cancers, or all lung disease. It causes 26% of all cancers, 11% of heart disease and strokes, and it's a leading cause of preventable death and disease, most significant risk factor in non-communicable diseases. So just again to sort of give you the picture, it is causally linked to cardiovascular disease, respiratory issues, reproductive issues, and other conditions, including cancer. So when you think about the clients that we have in residential care and what illnesses they may be or disease processes they may be bringing to those sites, a number of them fit into these categories. So tobacco dependence as a chronic relapsing disorder. And, I think part of the culture shift that we're experiencing right now is we've gone from tobacco being considered a lifestyle choice and a habit, something people can choose to do, versus sort of reframing it as a chronic relapsing disorder. In the Diagnostic and Statistical Manual for Mental Disorders, actually tobacco dependence is in there as a disorder. So it's a bona fide psychiatric addiction. Like I said, a common myth is that tobacco use is a choice or it's a habit, and the reality is that it is an addiction. And as an addiction, there's two sort of components to that. There is a physical addiction that's linked with the brain chemistry, and then there's the psychological or the behavioral conditioning that's the other part. So really when we're addressing tobacco dependence with clients or patients, we need to look at both of those factors. So this is the Coles Notes version of physiology. So what happens when you smoke a cigarette? And smoking a cigarette is probably the most common form of tobacco use, although nicotine dependence works for other forms as well. So when you smoke a cigarette, the nicotine is delivered to the receptor cells in the brain in 7 to 10 seconds. And it goes into the nicotinic receptors, and there's a big fancy name for those. So for those scientists in the room, it's the alpha, now I'm going to have to read it with my long distance glasses on, alpha 4 beta 2 are the primary receptors, although there's actually 4 different receptor sites that they go to. What those do is they trigger more in the frontal part of the brain, they trigger the dopamine receptors. And the dopamine receptors then produce a very pleasant feeling that we all just love, and it can be likened to sex or chocolate. When we look at addictions, when we're sort of assessing how quickly something or how addictive a product is, we're looking at the time from the craving to the time that it hits those receptor cells. And so when people say tobacco is one of the most addictive products on the market or available, it's because of that 7 to 10 second time frame. So the other thing that goes on in the brain is after a period of time, our bodies do what our bodies are great at doing, is they metabolize things that are there. And so within about 2 hours, the nicotinic receptors are now empty, and then the withdrawal symptoms or cravings begin. So I'm going to skip through this slide fairly quickly because I've already talked about most of this. What's interesting about tobacco is for people who are not used to smoking or have never used tobacco and then do, usually there's a feeling of nausea and vomiting and sometimes diarrhea. You don't feel very good. What happens with recurrent use is our brains upregulate, so there becomes more nicotinic receptors, and then having those receptors full with nicotine begins to feel normal. So the cigarette, in the tobacco world, we call it a highly efficient drug delivery system. And I could talk at length about how that drug delivery works, but given that I have 20 minutes or less, I will just suffice to say it's a very efficient system. So when we're talking to people who use tobacco, in my work in the clinical smoking cessation program, one of the first things we do is we use a tool called the Fagerstrom test, and the most important question in that is how soon in the morning when you wake up do you have your first cigarette? And what that really does is give us a sense of how addicted they are. And I actually had an opportunity to talk to Dr. Carl Fagerstrom, and he said if he was going to change his test, he would ask people, do you have a cigarette or do you smoke in the middle of the night? And he said, people will get up in the night and say they had to get up to pee. What's actually waking them up is withdrawal symptoms. And so they'll have a cigarette and then they might skew the time frame first thing in the morning. So I put this slide in, and actually if I only had one slide to show you, this would be my favorite one. The top red line that you can see is actually the blood nicotine level of where people feel comfort. And when their nicotine blood levels drop below that, they are in withdrawal, they get agitated and feel discomfort, and that's when they start agitating to go out for a cigarette. People who don't have any restriction, smokers are really good at titrating the blood level of nicotine every day, and people who smoke a pack a day do that 20 times a day. So again, I really like this slide. When we talk with facilities about how to address tobacco dependence in individual clients, if they smoke a pack a day, it means that if we've got smoke-free properties and smoke-free facilities, they're going to have to get out 20 times a day to maintain their blood nicotine levels. So why is this important in residential care? Well, for residents, it's a quality of life issue. And let me just qualify that before the whole room gasps. When people reduce their tobacco use and quit smoking, they actually have some fairly immediate side effect, or immediate, not side effects, because that's not really the right word, is it? But some physiological effects that happen. So within 20 minutes, blood pressure reduces. So when you have a cigarette, your blood pressure goes up. It takes about 20 minutes for your blood pressure to then come back down again. What clients tell us, or residents tell us, when they've quit smoking and they're in the seniors population, is real basic life skills get easier. So climbing the stairs is easier. Getting off the toilet is easier. So breathing, they're oxygenating better because they're not putting all that particulate matter into their lungs. It gets easier. The other piece around residential care that kind of factors in and makes it important is, within the province of BC, we have a Tobacco Control Act, and that's the act that says there's no smoking within 3 meters of doors, windows, and air intakes. And then within Vancouver Coastal Health, in Vancouver specifically, we have enhanced bylaws that say 6 meters, and in Fraser Health, I believe it's 7.5 meters. So that's about 25 feet from doors, windows, and air intakes. And then the province also deemed that all the health authorities across BC would have smoke-free premises policy. So again, I can speak for Vancouver. Within Vancouver Coastal Health, any healthcare facility that is solely owned and operated by Vancouver Coastal. So for residential care, there's a bit of a difference. We have owned and operated, and then we have contracted facilities. So we have smoke-free premises policy for the owned and operated, and the contracted facilities we get to negotiate with. And then there's WorkSafe BC. So WorkSafe BC deems that no employee in BC can be exposed to secondhand smoke. So whether they agree or they don't, the policy is no employee can be exposed to secondhand smoke. And we've had this within the health authority, if employees are exposed and they complain to WCB, then they come in and do a whole investigation and can charge the health authority with administrative fines. So so knowing all that, how do we sort of change practice? Well, in the program that I sit in within Vancouver Coastal Health, we have a clinical smoking cessation program, and really it's a standardized, systematic approach that's evidence-based to addressing tobacco dependence. And it's really based on the work that's been done by the University of Ottawa Heart Institute. People call it the Ottawa model. Really simply, it's kind of 5 key elements that you want to sort of systematize within the facility, which is consistent identification, documenting in a consistent way, giving strategic advice, and I want to qualify the strategic advice piece is really based on the intensity and the contact that you have with the patient. So I work not only with residential care, but with primary care offices, outpatient clinics, tertiary mental health. Depending on how often and how long clinicians are seeing their clients, they may do what's called a really brief intervention, or with most residential care facilities, you have more access and more time with your clients, so you could do a more in-depth intervention. And then when we look at treatment, we want to look at, remember, there's 2 components. We want to look at the physiological piece of that. So that's where your pharmacotherapies come in place, like the gum, the patch, the lozenge, the inhaler, or Zyban, or varenicline or Champex. And there should be a long-term follow-up. So we it's not like diabetes where you get, you wouldn't treat it that way. You wouldn't stabilize them once and then say, oh, you're good to go. With tobacco dependence, again, chronic relapsing disease, we want to keep following up and checking in because relapse is part of the process. We've really tried to coin it as a standard of care, so every intake, every time. And again, what our program offers is to work with facilities to help with education. And it needs to be, the education needs to be sort of not only just with staff, but with patients and with family members as well. So I've talked a little bit about what a brief intervention is, and again, different health authorities have done different things. There's something called the 5 A's, which we use. Some places use ask and act. Some people use 4 A's. And now I'm going to turn so that I'm actually on the same page as my slides are. Yep, I'm there. So, you know, the quick is we want you to ask and we want you to do something. We want you to do something about it. And the slide that I just bumped through really quickly is the evidence shows that as healthcare providers, we actually carry some weight when we ask. If we don't ask, it seems like it's not really a big deal. When we do ask, it shows that it's important. And the evidence tells us that when we do ask, it actually moves people along that continuum of behavior change, and they're more likely to quit. And if they are making a reduction or quit attempt, they're going to be more successful at it. So, again, when you're trying to change the culture of residential care facility, and we heard a lot about this, or we heard about this morning with the speakers, is, you know, how do you do that? Well, you need to do that with clear communication, and staff need to be engaged. They need education. You really need staff buy-in. You really need everybody singing from the same songbook. It needs to be consistent. There needs to be follow-up, and there needs to be support. And again, if you're going to, you know, launch a program, what you want to do in this day and age, anyways, from my perspective, is ensure that there's some sustainability to that. I think if I get lots of feedback from different clinics and facilities that I work with, it's like, oh, is this going to be just a flash in the pan, or is this actually something that's going to change the practice and change the culture? So a little bit about the products of pharmacotherapy. They kind of come into 2 categories. What we call nicotine replacement therapies, which are gum, patch, lozenge, inhaler, and then the medications, which are the Zyban or bupropion is the generic name, and then Champix or varenicline. Again, just if we discuss smoking cessation and smoking dependence or tobacco dependence support, if there's, you know, the no support, the success rate is 5 to 11%. That's the cold turkey model. If we use only the medications and only address the physiological addiction, then that increases the chance of success from 10 to 20%. And if we actually do some counseling, and so in residential care facilities, often that's sort of a one-on-one discussion or counseling with a client, and some facilities actually will build in a group process, so it's not a quit smoking group, but usually a talk tobacco group. If you do both of those, then that increases the quit rates or success rates to 30 to 40%, which is, you know, if you think of an intervention, those are pretty good numbers. And when we count sort of success rates, we're looking at maintaining smoke-free status for 6 months. Yep, and so aside from Vancouver Coastal Health and the support that our program offers, within the province there's also the BC 811 program. So, you know, if you were working with somebody prior to them getting into the facility, what you could do is make sure that they connect up with BC 811, and that provides some nicotine replacement therapy for people in BC. What I will say is for the bottom ones, the Zyban and Champix, you have to meet, to qualify for those, you have to meet the Fair Pharmacare requirements, and so lots of people in our province don't meet those requirements. But gum, patch, it's gum and patch for the BC 811 program, and they'll provide 12 weeks, or with a doctor's special authority, you can get 24 weeks. And then also, again, before they get into facility, there's Quit Now, and Quit Now is the provincially funded service where you can talk to a counselor on the phone, you can access it by the internet, and access it via text service. So that's the short version of tobacco dependence. Thank you.
Thank you, Ellie. Lottie, if I can invite you to come up, or if you feel more comfortable sitting there. And I'm going to ask Lottie if she could please introduce herself, as her bio was inadvertently missed.
Hi, hello everybody. So my name is Lottie Cox, and I'm the manager of clinical practice administration and quality outcomes for Fraser Health in residential care, and I am a long-time employee of Fraser Health. I've been there for, I guess, over 25 years, and in residential for the majority of that. Previous to this position, I was a CNS at Fraser Health. So I'm going to be speaking about the use of medical marijuana in residential care. And before I start, I want to disclose that I am not an expert in marijuana. But I am willing to share our experience in recognizing that this is an issue and kind of how we dealt with it and what the challenges were and still are. So it came to our attention that medical marijuana was being used in some facilities throughout Fraser Health, and we were starting to get questions from staff. Is this okay? Is it legal? Is it okay for me to be a part of this? Does Fraser Health support it? And so we knew that we couldn't sweep it under the carpet, but we had to address it. And so we began to look into the issue, and we asked the question, should people living in residential care have the same access as others to medical marijuana for symptom management? So we believe so in Fraser Health. So we decided to move forward with some investigation and looking into the development of a protocol to support the use. And so we recognize that there is a growing cohort of those particularly 19 to 65 that have had some familiarity with the product and who may choose to want to use it. And I'm just going to mention that I do believe this is a hot topic, and Duncan, my colleague there, he noted in the province this morning that there was an article about seniors high referring to the use of medical marijuana. It was in the community. But that, again, that's what I'll talk about is the context within residential care and how that applies for our setting as well. And Health Canada also, if you look at the Health Canada website, they indicate that the statistics have risen very significantly in the last few years. So it is becoming more common, but beginning to creep into residential care as well. And why not? So we looked at what guides us in development of the protocol. So first we looked at federal legislation and the marijuana medical access regulation. So that was our first stop. And we learned that while medical or marijuana is illegal in Canada for recreational use, that its use with permission by Health Canada is legal. So it allows access, this act allows access to marijuana for people suffering from grave and debilitating illnesses. But it is still a controlled substance and physician prescribed for a range of symptoms that are expected to provide relief where conventional or inappropriate or ineffective treatments have been trialed. So that's a key piece to remember. So, for example, it could be chronic pain, cancer pain, or muscle spasms are two very common uses that I know of. So then we looked at the knowledge and the evidence, and what we found is that Health Canada has done all the research for us. So in the Health Canada, if you look up medical marijuana on the website, you'll see a fantastic document for healthcare professionals and lays out the evidence, side effects, interactions, and anything you might want to know about this subject, clinical considerations. So I'll refer you to that for reading when you've got some time. So the next area was philosophy. So that's where in residential care we do have person-centered philosophy where we want to respect the values of that person and what they believe is important in their treatment plan. And so we believe strongly that we really needed to look into this and to move forward. Professional guidelines and standards. So as a nurse, of course, looking at to CRNBC for some direction. Looking at their complementary and alternative medication fact sheets and getting consultation from them was important. And then the context that we're talking about residential care. So that's a key piece that makes it different from the community. is that our residents, they live in congregate care, right? And as such, sometimes we need to place some boundaries around to protect the safety and the comfort of the other residents. So just a few details, just to give you some background about the Act itself. So the first requirement is a medical declaration from the physician, and he does need to declare that for the symptom in question, that conventional treatments have been trialed, and then he needs to identify what the appropriate dose would be, form, and the route of the marijuana. And then authorization to possess. So if somebody wants to use medical marijuana, they need to apply for an authorization to possess. And this document will indicate the person's information, the amount of marijuana that they can have, and where it's obtained from. And it requires renewal every 12 months, every year. They can get marijuana from a government authorized provider. So Health Canada has their own farm, I guess, or whatever you want to call it, in Saskatchewan, where they produce it. And yeah, I don't really know much, honestly. So they do produce it there, and you can order it directly from Health Canada, or you can order the seeds as well, and then you can have somebody grow it for you, with permission, of course, from Health Canada. And then this person can grow it, a limited number of plants, and then they can provide that to the person who has the authorization to possess. And then providing assistance is another key issue, especially for our setting, where people are not always as capable. So there is I believe it's Part 1, Section 23. It clearly lays out what kind of assistance a person can give a person who is authorized to possess. And so someone can hold the marijuana and give it to that person if they have the intention of assisting them with taking it. So that's also laid out in the regulation. So developing the protocol, we clearly laid out the resident responsibilities so that they can give the facilities assurance that they have gone through the legal process of getting the authorization and the marijuana itself. And we indicated no smoking on facility property. And the reason we did that is because the risk was felt to be too high, that there's possibility of sharing could happen, which is not allowed. And butts can be dropped, if they're smoking, they can be dropped on the ground and other residents may pick it up. There was just too much risk in that, so there's no smoking on facility property. There must be an individualized care plan in place, a very key issue for ensuring that staff are very clear on what they're allowed to do, what they can do, what the resident should do, and what the process is. It's a key communication piece, and also it's kind of if the staff see that something is not being adhered to, it kind of gives them a clue that there could be something unsafe or something not appropriate going on. The physician writes an order, and we put it on the medication administration record that the marijuana is being used and that it's the resident's own product. And then we also have developed a document, a formal agreement, to ensure that the manager or whoever is working through the process has a bit of a checklist so that they know they've covered all their bases and they know they have done all the considerations that the resident and the manager would then sign off on it. Because there does need to be team agreement, right? Even though a physician may think it's appropriate, if the person doesn't agree to, say, providing safe storage or to agree to the whatever is laid out, then it can't happen. There needs to be agreement from both sides. So basically, I'll just run through the process. First, you need the physician's support, and he does the medical declaration. The team from the facility meets, and they make a plan for the administration, the handling, and the storage. Storage is another key issue again, because we have residents, like we talked about earlier, who wander and so forth, and so it needs to be very carefully locked away. And then the agreement is signed, the physician writes the order, the resident then provides the authorization to possess, and we make a copy. The plan of care is developed and made available to all the staff, and the nurse would then document her knowledge of the resident participation, and then the care plan is reviewed quarterly or as set out by the care team, or if there's an issue. And so just focusing a little bit more on the care plan, specifically, oh, you like the brownies? They look good. Yeah, the nurse may provide assistance to self-administer, and so that needs to be, if that's required. Some of the residents don't need any help at all. They can manage physically, but if the nurse is involved at all in the process, she needs to know that she can take the brownie or cookie or whatever it is and give it to the resident, but the resident then would self-administer. And then the nurse would do ongoing assessment. She'd use her clinical judgment to determine how the symptom management is going. There's potential for drug interaction. For instance, if it's being given for pain, opioids may need to be adjusted and so forth. Then the resident responsibility and accountability. So this is another really important piece, that they have the cognitive ability to obtain the authorization, because it is a really complicated process. I had to read it quite a few times to kind of understand it. So they need to have that ability, and they need the external support to be able to get the marijuana. If somebody's going to grow it for them, then they need to have that arranged. If they're going to make the brownies or the cookies for them, they need to have that arranged and have it delivered. So it's not to compromise the health or well-being of other residents. So sometimes use of marijuana brings with it some visitors, that happens, and so they they should know that there's no sharing allowed and so forth. But sometimes, and I've got no evidence to indicate that that's happened to date, but you wonder, right? You wonder. And then the resident needs to have knowledge and adhere to the regulations. So they do need to provide that safe storage for it, and to renew the authorization when needed. And so really it is a balanced approach that we're striving for, to demonstrate respect for the rights of the resident, and then at the same time to provide the access, considering the rights and safety and health and comfort of all the other folks that are in the facility. So I'll stop here.
Thank you, Lottie. Duncan, have you had the same training on how to get your PowerPoint out?
I'll give it a shot.
Thank you. You can join me in welcoming Duncan Steele.
Thank you. So hello everyone. Can you hear me okay in the back? Great. Does everyone, just before I start, does everyone have a copy of, there's a handout that went out at lunch hour? Okay, great. If not, there should be hopefully some extras at the table, or you can share with your colleague. I apologize, I didn't bring enough copies, so I had to run downstairs and get some made in black and white. They didn't turn out as well as I'd hoped, but hopefully when we get to that part of the presentation, you can follow along either on the handout or with your neighbor. So, oh, perfect. I didn't get a chance to... Kelly, are we doing questions at the end? Like after? Okay. So I guess we're doing questions afterwards, so that's fine. My name is Duncan Steele. I'm the coordinator with Ethics Services at Fraser Health. I'm here to talk about a clinical practice guideline that we've finalized in Fraser Health. It's titled Supporting Residents to Live at Risk in Residential Care. It's a clinical practice guideline with a policy supporting it. And one of the goals of being here today, I'm glad to see there's some faces I recognize from Fraser, but also a lot of new faces who I haven't seen before. So I'm glad of that, because one of the goals is to share this work in case it's something that you might find useful in a different region or in a contracted facility or what have you. So I thought the kind of plan for the presentation is I give you a quick context of why and how the guidelines were created, so you know where they're coming from, and then if we could actually look at the kind of action part of the guideline, a decision-making or decision-guiding algorithm, and I have a little case study that goes with that, and then maybe in the question period, if you have any questions, or afterwards, in the break, we can chat more. Where this came from is it began with you might be wondering, why is a guy from Ethics Services up here talking about it? How it started was a clinical ethics consult at one of the residential owned and operated residential care facilities in Fraser Health with a resident who had multiple sclerosis and was losing their ability to swallow solid food, but also still desired to eat solid food. It started out at a clinical level just with the one case, and the manager and the team there recognized that it was something that had come up before, and they expected the same kind of issue to come up again, and that the staff found it really challenging, and the families and residents found it really challenging. There wasn't a clear guideline, and it wasn't consistently the same across the different facilities or even at the site. So it became kind of broadened and solidified into a system level ethics consult, which is something we also do or help to facilitate. And then after about a year, that all started in 2009, I think. After about a year, it had worked out fairly well for them, and so there was a decision made that to become a regional guideline for all of Fraser Health. Just giving you a little context. So, as Lottie already pointed out, this has to do with the philosophy that operates in residential care at Fraser Health around person-centered care, a recognition that demographic changes are happening. The same narrative that has probably gone on this morning as well around the baby boomers are expected to come into residential care and will be more assertive about what they'd like. And then also this piece that I already mentioned, which was that this distress that the staff was feeling, managers were feeling, and the residents and families and loved ones and friends were feeling, because it was inconsistent and it wasn't transparent, and it's a hard issue to work through, and so was leading to a lot of distress all around. Probably many of you can identify with that. So broadly, this is the focus of the guideline. It's an algorithm to help staff respond to individual residents who engage or are requesting to engage in behaviors that put them or others at significant risk, and to respond to family members or loved ones who make requests that could put the resident or others at risk. This section was titled on alcohol, drugs, and tobacco, and this guideline would apply to that as well. But the focus of it was around, it came up through the eating at risk. It was around residents using power wheelchairs and maybe hitting other people. Smoking came into it. Falls came into it a bit. And it overlaps with some other guidelines in Fraser Health, such as medical marijuana, the falls prevention, stuff like this. But it would apply, the case I'm going to talk about is around eating at risk, but it would apply equally to drug use, alcohol use, tobacco use. Just a little background on the work that went into it is that it was this ethics consult, but what I really wanted to just emphasize was that it was a long process that was quite rigorous, that really looked to the facts of the situation, the context across the different facilities in Fraser Health, across the relationship with acute, how they feel about the difference with living at risk, kind of the tolerance for living at risk in residential care versus in acute care. And there was a lot of consultation and a lot of involvement in a rigorous process, which was endorsed last year by the Residential Care Assisted Living Program leadership. So it was put into implementation last summer. Broadly, we're not going to look at all of this. It's a big document. It's about 30 pages long, though it is thrilling to read. The clinical practice guideline consists of two pieces so the guideline itself consists of a bunch of information around when to use it, what is the rationale behind it. That piece we felt was really important, is rather because it's a difficult situation for everyone involved, and there's a lot of values at play. We thought it was important that the CPG itself have the rationale for why we're saying that we ought to act in this way and why we ought to follow this guideline, rather than just having a CPG that has a decision-making framework in it and no kind of corroborating or supporting argument. Then we'll be looking today at the decision-making algorithm itself and the support tools, and not the policy. But if you're interested, like I said, one of my hopes of being here today is sharing this with you, maybe piquing your interest, or you see that it might be useful back on your own sites. And then I invite that you get in contact with me, or Lottie, actually. So I thought we could switch gears now. Usually I'd ask for questions, but if you have any, maybe just write it down and we'll talk about it in that period. If we switch gears and go through a case study, and I apologize, it's very small, and also apologize, I'm going to read it out loud so make sure everyone knows what it says, because it's hard to read up here. So if you want to grab the handout or have it at the ready, I'll just, bear with me. I apologize. So Mr. D has multiple sclerosis and moved into Shady Rest Residential Care Facility about 4 years ago when he could no longer care for himself at home. His wife left him years ago after he refused to access any type of home supports, and instead heavily relying on her for all of his physical and emotional support. Their 3 children live close, but they don't come around very often anymore because they have a hard time dealing with their dad. Over the past few years, Mr. D, his condition has deteriorated significantly. Previously, he was only confined to a wheelchair and only required assistance for minor tasks. He now requires assistance with many things, including feeding. His ability to swallow solid foods has seriously declined recently, and staff members at Shady Rest have begun to hear a distressing cough when he's eating even the smallest bites of food. Last week, Mr. D seriously choked while being fed a meal of solid food. Luckily, there was a senior staff member just outside the door, and she managed to dislodge the food and provide him with suction. After this event, the OT was asked to conduct a swallowing assessment, which Mr. D failed, and he's at serious risk for choking or aspiration. However, Mr. D insists that he be fed solid food, and that if he chokes, he's fine with them letting him die. He says that since his wife and family aren't interested in him, he has nothing to live for, and solid foods are the only thing left that he enjoys. A number of staff are talking about refusing to assist him with eating solid foods. They don't want to watch him choke or be blamed if he dies, or feel the guilt associated potentially with assisting him. So that's a case, probably some of you can relate to that. If we look, so if you want to flip to the first page of the handout, if you look there, that is the first step, the starting step of the decision-making algorithm. And I'll just, if it's all right with you, I'll just walk us through this case, through the algorithm. And we'll have a chance to look at it. I've chosen a case that's fairly straightforward in a sense, so that we can do this quickly. If we wanted to talk about a more difficult one during the question period, that would be great also. So, question 1, could the decision or behavior result in serious illness, injury, or death to the resident? I think the answer is probably yes. So you follow the branch. Question 2, does the resident understand and appreciate the consequences of the decision? And we recommend review of support tool 1 to make this decision. So if you flip to the next page, It's titled Support Tool 1, Assessing Decisional Capability. So as we go through the algorithm tracks each of these branches, represents or follows some of the main values that we said were priorities, really, really important. And so there was stuff around minimizing harm to the resident, also respecting the resident's values and preferences, beliefs. There was part around minimizing harm or avoiding harm to others, around staff integrity, and around organizational integrity. So you'll see as we go through that some of these values are coming out. I don't think I'll read through this whole support tool, just so that you know that it's there. There's these additional support tools that are meant to kind of enhance the decision-making algorithm, not as a recipe that you have to follow, but more as a guideline to help staff if they're in a situation they're thinking, this is going to be a really difficult conversation to have, I'm not sure what to ask. This outlines some of the things to ask and some of the things to think about. So being aware of the residents' decisional capabilities, there's some things there to think about. But I think I'll skip it for now and invite you to read it at your leisure at another time. If we said yes, we concluded that he is able to make this decision for himself. He understands the context and the possible consequences. So we go to yes. To the left here, does the resident want us to share the details of the decision with any family or friends or loved ones? We're not sure. We'd have to ask Mr. D. Whether he says yes or no, we'd proceed to the harm to others track. So as you see, if you skip forward in your handout, there's support tool 1 is in there, support tool 2 and support tool 3 that I'm not going to go over right now. But I'll just sum them up for you. Is that support tool 2 is around substitute decision making. It gives some guidelines for what to think about when you, as the staff member, are speaking with a family member or a friend of the substitute decision maker. Things to think about in terms of keeping the residents' own values and preferences central to that conversation. So instead of asking, what do you want us to do with your dad, asking, what would your dad want us to do to support him, framing it around him being central rather than their preferences being central, which was another one of the values that came up. And support tool 3 is around support for family, friends, and loved ones, and gives some guidelines for when you're having what could potentially be difficult conversations with family. Some things to bear in mind. These were things that came up from our shared work team as pointers that they thought might be helpful to staff in these types of situations. So we flip to the next page with the 3 tracks altogether. The harm to others track is, could the decision or behavior result in serious illness, physical injury, or death to others? Yes or no. In this case, no. And some people are often in doing the education for this, people say, well, what about the staff? And the staff do come at the integrity track. So we're just talking about physical injury. In this case, no. So we'd go to the policy track. And in this case, is the decision or behavior in alignment with other formal written Fraser Health policies, procedures, clinical decision support tools? Check with this clinical policy officer or contact a CNS in absence of a policy, proceed to yes. And I'll just step out for a second. And when Ellie was talking about smoking, this is one of the pieces where if we look through here, we'd say, the Fraser Health policy and the WorkSafe BC guideline and the BC legislation would say that no having someone smoking in the residence or in their room or what have you isn't in alignment with that. So we'd follow and say no, but can the decision to live at risk be modified to fit a policy or procedure? And that's where we'd look at, well, is there some type of harm reduction, therapeutic alternatives, that sort of thing? Is there something kind of care plan that we can do to modify this and still support them in a sense, but maybe not support them as fully 100% in the way they want to do it, but as much as possible. So I just wanted to give that kind of tie it in to the smoking piece there. But in this case with Mr. D, is it in alignment with formal policy and so on? Yes, it would be, because this is, in a sense, what we're reading is the formal guidelines and policy. So we go to yes, the integrity track, and this is the piece around staff, is that our specific staff members feeling as though the decision or behavior compromises their integrity. And the answer here is yes. We've seen in the case that some staff members are very upset and feeling distressed about the situation for different reasons, and we follow the track here around confirming that the safety supports are in place for Mr. D, so that as much as possible, for example, there'd be a nurse or an LPN or a care aide who is able to provide suction or what have you to reduce the risk as he's eating solid food, and so forth. And there's another, if you flip to the last page, is the final support tool, and that's around if staff are feeling distressed, some pointers for providing support for them and so on. So broadly, in a quick run through, I hope that's what the clinical practice guideline looks like in brief. And as I said, wrapping things up, as I said, if you're interested in seeing the full guideline, we're very happy to share it. We'd be very happy to share it. And my contact info is on the front of that handout. You can contact myself. Lottie Cox, I don't know if I said at the beginning, Lottie Cox was actually very involved with the work early on as well in her former role. And there we go. So you can contact her as well. Thank you very much.
Thank you. Thank you, Duncan. Are there any questions from the audience? I remind you please to come up to the microphone so that your voice is taped for posterity.
I feel like I should start this with, dude. My name is Elizabeth Harris. I'm with Baptist Housing in Kelowna. Interior Health Authority has come out probably in the last 4 or 5 months with some policy around marijuana and assistance with that from terms of caregiver assistance and residential care. And the policy is basically looking at the ability, all those pieces of the resident responsibility, having the card, having the problem became when, even though prescribed by physician, it was family members that were bringing it in. So the team members are being asked to assist, give them the brownie, give them the cookie, and you don't know what the dosage is that's in that. And so basically in the interior, our teams are not assisting. They can get assistance from family, compassion group, whomever it might be, but our team assistance doesn't happen. And it won't happen unless there's some mechanism to regulate so that they know the amount that's being administered. So that became the big issue, the brownies, the cookies, and that's how a lot of it was coming in.
Hello, is this on? Yeah, yeah, I agree that we'll never know, because we don't know for sure how much is in it. And I had that conversation with CRNBC as well, and that's where they drew the line, was that staff could, if they felt okay about it, like morally okay, that they could remove it from a fridge or a location, and give it to someone, but the staff would not be involved in the administration. It would have to be self-administered, or the families would have to participate in that process.
Thank you, Lottie. Another question? Brad?
Yeah, I'm Kevin Smith. I'm with the BC Centre for Elder Advocacy and Support. We had a caller who was complaining about marijuana use in a facility, but I thought it was about the smoke. It took me a while to realize she was talking about the smell of the herb itself and the grinding up of it and the rolling of the cigarette joints is there anything about that in the policy that you developed?
Yeah, well, that's part of the comfort of the other residents, right? Is the odor can be very disagreeable, I guess. And we do have a note in our protocol about odor, that it needs to be controlled, and that if there is any odor, they need to either take some measures to reduce the odor or eliminate the odor or they can't use the product. So if you're not smoking, that takes away a lot of the odor. If it's just in the brownies or the cookies, what I understand is that there is some still possibility of some odor, but if it's wrapped properly and put in a secured storage, then that minimizes it. Yeah.
Well,
go ahead.
I was wondering about it. In a past life, I was dealing with smoking in facilities, and there was a regulation that you had to have one room that would have positive air pressure, so that you open a window and everything went out the window because there was enough air pressure in the room. Is there any possibility of a facility having a room like that to allow smoking and or the odor of the herbs and rolling the herbs there or something?
Okay, I can answer that from a tobacco perspective. When sort of tobacco control sort of first started rolling out, and there was legislation that was passed around smoking rooms in bars and restaurants, there was actually a lot of discussion and research around ventilation systems and positive pressure and moving that particulate out again around, in light of the WCB regulations where employees can't be exposed. And currently, to the best of my knowledge, there is not a ventilation system that actually would move that, or a positive pressure that you could put in the room, that would actually make it a safe environment. That particulate matter travels, and in the tobacco world, sort of a rule of thumb is if you smell it, then your nose is picking up particulate matter and you're breathing it. So there, like I say, there's been lots of research and lots of hypotheses about what might make a room safe, but to date nothing's been developed that does that work. Lots of jokes around the cone of silence from the science world cartoons, but no, there's nothing on the market that actually makes a room safe.
If I may ask a question of the panel, this is not drugs or alcohol related, but when talking about elder abuse and the right to live at risk, and I'm thinking about when you have visitations from family at facilities and you see emotional abuse, you see various other kinds, spiritual abuse, etc. What sort of tolerance is there for living at risk when you're seeing a form of elder abuse other than overt physical? How does that fit in? Does that fit into this paradigm, this model?
I'm not sure.
I mean, I do see that there could be an element of abuse. I'm not sure I'm answering your question, but I'm going to give you an example for marijuana. And it was, there was a discussion once around the potential for elders in residential care to be abused by people from the outside who offer their services and say, well, if you request medical marijuana, I will... if you request it, I'll grow it for you, right? And then meets their needs as well. But I mean, there is potential for abuse within this. I see that, but I'm not sure it fits with the algorithm as Duncan has presented. But I think it's something that we really need to be aware of, though, certainly that exists.
Thank you. Other questions from the floor?
I'm Laurie Chiasson. I work at Evergreen Baptist Campus of Care in White Rock, and I have a few questions. One, can you get marijuana in a pill? Or is it just you'd have to ingest it by...
It's the synthetic. There's a synthetic form in a pill.
Okay.
Marinol, I believe.
Okay. The secondhand smoke regulation, is that, like you mentioned, this, if you can smell it, it's there. We have a few clients that are allowed to, they smoke. We have a smoking area in assisted living in Fraser Health, and we have outdoor smoking. One person, the smell stays on him all the time, and I get complaints from staff where they get headaches going into his room after he smoked, I'm not sure how long ago, and they don't like to provide service. So does it apply to that as well? Secondhand smoke, just residual in clothing and...
So there's evidence and there's literature around secondhand smoke, which is, you know, the smoke that is actually exhaled. I call it off-gassing, but is exhaled from people's lungs, you know, as they exhale when they're smoking, because you don't actually breathe out and clear all that particulate matter out of your lungs by going and then going inside. There's research around that, that we can name it as a known health hazard, as a carcinogen, that the same particulate matters that are in cigarettes actually are in secondhand smoke. What's on the horizon is sort of the issue that you're talking about, which has been labeled as third-hand smoke, and it's the particulate matter that stays on inanimate objects. So, you know, hair, clothing, Chesterfields, and our health authority, and I believe all the health authorities, have a regulation for home care that if you're going into somebody's home, that we need to ask them to not smoke for an hour before you go in. That's somewhat arbitrary, the 1 hour mark. I think it was a discussion of what felt reasonable for providing care. There's not a lot of evidence to support whether it needs to be an hour or 5 hours or a day. And so as far as the third-hand smoke, there isn't any evidence to say at what level or how much exposure causes harm. And because of that, there's not at this point policy around that, because we don't have any evidence to base that policy on. Okay. I hope that answers your question a bit.
Yeah. The other one is along the same line. So one of the clients that smokes also does smoke marijuana and doesn't have an order for it, but he smokes it off-site. But we smell it on him, so we assume. So I'm not sure, again, assisted living, the right to make choices. Do we ethically do anything about it or not? It's not on our property that we ever catch it, but it comes up. It's a bit of a concern by some.
That question does apply to the process that I was talking about earlier. One of the big pieces in here, sorry, I'll get close to the mic. I was just saying that the question does apply to the algorithm that I was speaking about earlier. One of the big pieces of this, the algorithm, was around recognizing that, and Kelly spoke about this when she introduced the topic, was, is there a difference between someone who's living outside of the residence or assisted living and whether they're living inside the institution, and how should we treat them differently? And one of the big values that you might imagine from what I was saying is that we don't treat it differently, that as much as possible we recognize that everyone in this room is living at risk day to day, and how we choose to come to this conference, whether it's by car or walking or biking or taking the bus, there's different levels of risk associated with that, as well as whatever we do in the rest of our lives. We make decisions constantly to live at risk, and so applying a different standard to folks just because that they're vulnerable and then need our care, whether it's an assisted living or residential or what have you, we felt that wasn't fair. So if you went through the algorithm process, the result would be part of the result or outcome would be that you'd have the conversations with this individual and make sure that they had a really good understanding of what they were doing. To put it in more context, the algorithm that mental health and substance use at Fraser Health is thinking of adapting this to their residential care facilities, and what they're worried about as far as the risks is not eating at risk. It's not a powered wheelchair running into folks. It's more around that, people using substances off-site, whether they're coming back to the site intoxicated or not, these types of things. And so I think I lost my train of thought there a little bit, but I hope you saw where I was going better than I did.
Yeah. Okay.
Thank you.
Thanks.
Good afternoon, and thank you. Joy from Augustine House in Ladner. We're primarily assisted living. I'm just curious, particularly Ellie and perhaps yourself, Duncan, as an ethicist. I clearly recognize where we need to be with the non-smoking, even non-smoking in our building with respect to other residents, et cetera, et cetera. But the flip side of it is the 85-year-old that smoked for years and years or things like that. I think we do a real disservice to these residents. And is there anything on the horizon for these people? Because our expectation, you know, smoking's bad, you can't do it. And I'm one of them. I'm on that bandwagon, and yet we are doing an incredible disservice to an elder who has smoked all their life. Your thoughts on the type of care they deserve? It's not our right to necessarily insist they quit if that is their only pleasure left. And many a resident has told me that. We recently evicted an 87-year-old, or perhaps were saved the eviction process because she and her family chose to move to a building that supported smoking. But that piece of it, we are doing a disservice to those residents who define smoking as their only pleasure. Your thoughts? Thank you.
I knew I was going to get this question. So my thoughts. You know, the culture is changing slowly. And so when you get the scenario of the 87-year-old person who's been smoking forever and it's their last pleasure, part of the challenge is to peel that onion. And I'll lay a bit of a foundation. What we do know is that most smokers want to quit. And that's sort of across the board. So whether that's the mental health population or whether that's the general public, you know, the number comes in usually around 70% of smokers want to quit in the next 6 months. So, you know, what resonates a little bit is your thoughts about sort of elder abuse. And again, with addiction, it's not a clear path. Is there family members who, you know, don't want to? Is there family members who are promoting this is mom's last pleasure, et cetera, and that's part of what's driving it. So it's really a consultative process to look at that. We do have stuff in place. And so, you know, we do have a clinical practice guideline around smoke-free and withdrawal management. We do have nurse-initiated nicotine replacement therapy orders and nicotine replacement orders for physicians and nurse practitioners and pharmacists. So if you're in a smoke-free facility and you can't smoke in the facility, there's not an expectation from my perspective that you're going to go cold turkey and suffer. So there actually is tools in place to make that transition to being smoke-free, but still manage the addiction like we would manage any other addiction.
I certainly have appreciation for that. In this particular case, it was the resident herself, clearly cognitive, no intention.
Yeah.
And she was, I mean, we did the things that you're recommending, and we were just really, and to have this 87-year-old move, it was just rather a heartbreaking process, I guess, if anything, but her refusal was very adamant.
You know, and like I say, I think we have to address those one resident at a time and one client at a time in a very, you know, respectful way. I don't know whether we don't have policy and we allow smoking rooms because there's the one, you know, there's going to be a percentage. I remember John Blatherwick, the medical health officer for Vancouver, you know, saying at one point in time, there are people who have addicted personalities and they're going to be addicted to something, and you can do everything right and they're still going to be there. So, you know, do we not move forward with policy because we're going to have these scenarios where there's the one person who's absolutely adamant that they've smoked all their life? I mean, the other piece that I run into with residential care that's an interesting conundrum is as cognition wanes, at what point are they actually making informed consent to choose to smoke?
versus the staff enabling a behavior that's always been there. I mean, that again is another really interesting ethical question about at what point does that shift where people are making informed consent to take the risk to live at risk. And I don't have an easy answer for you.
Can I jump in and say?
Sure.
Is that okay? I'll just be quick. So, without knowing more about the individual case, the kind of two or a few things that came to mind is why whether it was harm to others. Was there a worry that she was going to fall asleep in her bed? Was she smoking inside?
The offensiveness of the odors that walked in through hallways and even out open doors up to higher level suites. So complaints from residents.
Sure. So just for everyone else, it was offensiveness to odors that were wafting through the building and up to floors above. So I look at something around more of, is there a way to support that in terms of can her family come and take her out for lunch and she can smoke while she's out for lunch or something along those lines. But I don't know all the intricacy of the case, so I'm sure. But then I'm going to say something that might be a little bit controversial that came up during the process of doing the clinical practice guideline work, which was one of the OTs who was talking about falls prevention and how this related to falls. She said that, and when talking to families, communicating to families, and families were kind of saying, no, we want the lap belt, or no, we want all the bed rails up, and not realizing the dangers or the discomfort that those can cause. And she said, what are we keeping them alive for? Which is a harsh thing to say. I hope it doesn't offend anyone. But just in terms of keeping something in mind that it really stuck with me profoundly was, it's everyone is going to die, and the average life expectancy, I think, in Fraser for residents is 2.2 years once they've gone into a residential care, not assisted living. So in terms of that, is it an added burden at the end of their life? So I'm, in a sense, I'm sort of disagreeing with Ellie, not entirely, I apologize, but it's just a different perspective is why are we kind of pushing them in this way or trying to make them healthier right before they're going to pass away or what have you. So thanks.
Thank you. We have time for one more quick question. Please.
It's not a question. It's this is Lana Thompson. I'm care coordinator at a facility in Fort St. John, and we went through a smoking cessation program for all of our residents who couldn't get off ground. It was a very positive experience for us. Our dementia unit became a very nice place to work, and we had lots of examples of where lifestyle they were more able to enjoy their life without going through withdrawal once an hour when they were getting their cigarettes. It can be done.
So I'll leave you with this. And it sort of speaks to, if they're going to die anyways, why are we doing this? We had a similar process with one of the facilities. There was a lot of agitation with the family and the parent who was in the facility who, didn't want to quit. My last pleasure. The family saying, Mom doesn't want to quit. Her last pleasure. We went through a whole smoke-free properties process with staff and everybody involved, and the whole facility went. Part of the reason they were going is they had 2 fires within 2 months, and so we had to address the issue of smoking in the room. Or in the residence room, and hindsight's always 20/20. So these are the nuggets that you get after the fact. The family came up and said, I know we were awful about it, but I want to say that we really appreciate Mom having to be smoke-free because the last little bit of her life was so much better. Her cough was better. Her oxygenation was better. Her cognition was better because, from my nursing background, it's because her blood oxygen wasn't, she wasn't running at 40 parts per million of carbon monoxide in her blood. She was actually down probably around 2 or 4. So, so I said to them, can I use your story? And they're going, of course, yes. And so I'll leave you with that story that even, for the last, and I'm going to guess here, but I think it was about maybe year and a half, this family saw that it was actually worth the journey for their mom.
Well, I have several more very controversial questions, but I'll try to withhold myself. So I know we all need to get out for our own personal fix. Mine particularly is chocolate. Do you have a please? So thank you very much. Thank you to the panelists.